welcome back to my YouTube channel. This is Medicine Unfiltered with Thelma. You can call me Dr. Bonsu as always. Thank you for watching my previous videos. Like I said, we're just getting our feet wet. We're just coming back into videoing and making content. But today I wanted to talk about something a little bit heavy. It is not very common in the Ghanaian community or in the African community, but since I'm Ghanaian, I'm just going to really speak about the Ghanaian community, and at some point I would also explain it in my local language, which is Twi, so that some older adults who are listening will be able to understand it. But it is for everyone of age, I would say, who's able to make their own decision. So today, what I am talking about is co-status. If you've heard of co-status, great. Most people in the healthcare system know about co-status. It's mostly similar to a living will, kind of, in a sense, when you are in the hospital, like what you want us to do for you when you come to the hospital, basically. So whenever you go to the hospital, or at least when you come to the hospital I work in, whenever we are admitting you or into the hospital, we ask about your co-status. And mostly, like I said, it's really what you want us to do for you in the setting of your heart stopping. So when you die, or when we think you are dead and your heart is stopped, everything is not working anymore. In that moment, what you like us to do for you. There are some nuances that comes with it, but in a grand scheme of things, or basically that is what it is. So when you come in, we ask about, hey, do you know what a co-status is? If you know what a co-status is, what is your status, or what would you like us to do in case your heart is stopped, in case we think you're dead? Okay. In the healthcare setting, and I say in a healthcare setting because EMS also recognize different things sometimes, especially if you are DNR, CCA, they do recognize one portion of it, but in the healthcare setting, this is what we tell you when you come in. So if you don't know about it, we ask you, okay, do you mind if I talk to you a little bit about it? Because you have to choose one. You don't have to choose it at that time, but we would want for you to choose one whilst you're in the hospital, so that just in case something happens, we know what to do. But in the healthcare setting, in the hospital, the four big things that we talk about are full code, DNR CCA, okay to intubate, DNR CCA, do not intubate, and DNR CC. Full code. Full code means in case we think you're dead, in case we think your heart has stopped, you would like us to bring you back to life by doing chest compressions, putting a tube down your throat to help support your breathing, or intubating, and doing everything in between, whether giving you medications, whether pushing IVs, whether doing imaging, CAT scan, MRI, doing everything within our wheelhouse until things are unsuccessful, and then obviously we stop at that time. But full code means we do everything. We are aggressive until we are not able to, by medical decision. DNR CCA, okay to intubate, is do not resuscitate, comfort care, arrest, which means in the case you die or your heart stops and we think you are dead, we will not push on your chest if your heart has stopped. But if you are okay to intubate whilst you're in the hospital before your heart stops and we think you're dead, whilst you're in the hospital and we are doing everything we can, just in case your breathing becomes abnormal, you're not able to, support your own breathing, your oxygen is dropping lower and lower and lower. If you are a DNR CCA, okay to intubate, you are giving us, or you're giving providers, the opportunity to put a tube down your throat to intubate, to put you on a big machine to help support your breathing. And we also do everything else. We give you medications, we do all the scans, antibiotics, IVs. We do everything. We do everything in our power to help you survive until you are dead or until your heart stops. We don't push on your chest to bring you back to life. We do not do CPR. So full code is we do CPR, we put a tube, we do everything else in our wheelhouse. DNR-CCA, okay to intubate, means we do everything else. We help you with CAT scans, MRIs, medications, everything else. When your breathing becomes abnormal, you're having trouble breathing, we will go ahead and put a tube down your throat to help support your breathing up until you either hopefully come out of your situation or until your heart stops, where we think, okay, you are dead, that we will not do CPR at that time. Okay? And DNR-CCA, do not intubate, is basically what we are saying with DNR-CCA, okay to intubate, but you are giving us the chance to, okay, when your breathing becomes abnormal, you don't want any, life prolonging events that you may be on the vent for however many weeks. You don't want that. If your breathing starts to get abnormal, it's fine. You don't want any big things. We will put you on Big Max to support your breathing as much as we can, but until the point where you're becoming more hypoxic or you're not retaining CO2, then we will not put a tube down your throat. Then we say, okay, the only way we can help you support your breathing is to put a tube down your throat, but you don't want it. Your DNR-CCA, do not intubate. You don't want it, so we'll put you on a max as long as we can. But if that is your only option, then at that time is when we say, okay, we can leave you on that max forever, so you have to probably say your goodbyes. Your heart has not stopped then, but your breathing is also because if you become hypoxic or your oxygen drops, you can end up making your heart stop. Okay, so at that point, if you don't want that, but we do everything else. It's just like the DNR-CCA, okay to intubate. We give you medications, we do all the imaging, the CAT scans, we do everything else to help you. If your blood is dropping, we'll give you blood. If you need surgery, well, that's a different thing, but we will do all of these things up until your breathing becomes abnormal, and we've supported you with other things outside of putting a tube down your throat. Then we don't do that, or up until your heart stops. So if your heart stops before we have to put a tube down your throat, we won't push on your chest. If your breathing becomes abnormal before your heart stops, we won't put a tube down your throat. But we do everything else to either keep you alive or help have family come around to be like, okay, this is the end. Okay, so I've explained 3 of them. Full code, DNR-CCA, do not resuscitate, comfort care, arrest, but you're okay to intubate or you're not okay to intubate, which is put a tube down your throat to put you on a big machine to help you breathe. And the last one is DNR-CC, do not resuscitate, comfort care. That is sometimes quite tricky for people to understand, but DNR-CC, do not resuscitate, comfort care means at this time that you are in the hospital, you should probably, if you're DNR-CC, you should probably not be in the hospital to get all of these life-sustaining measures. But when you come to the hospital and you are getting worked up and things are looking not great, and you choose to be DNR-CC, then at that time we stop all life-sustaining measures. Okay, we stop everything that would prolong your life. We don't give you anything that would say, okay, I'm comfort care, give me something to make me pass quickly. No, we just don't give you things, or we just don't do things that would make your life prolong. We just let natural causes or natural life takes its course. So if you become DNR comfort care, the big thing is once people become that, we, depending on where they are in their stages of passing or in their life, they may be very close, but sometimes you don't know. You don't know if it's going to take them a day, 2 days, 3 months, 6 months to pass. So at that time, based off of medical decision, the family or the patient could choose, if they're on the oxygen, they could have oxygen on for comfort, but not to, support their breathing in the sense that they're dying. So they could have it on for comfort, because sometimes people have it on and it feels like they're breathing well. And most of the time they're in pain or one way or the other, they're anxious, their heart is racing, or there's something going on. So at that time, we can give you some medication to help with your pain, to help with your anxiety, to help so that you don't choke on your own secretions. That will make you pass maybe earlier than your natural course. Okay, so all of these things are, but we don't go back and do an MRI because you just want to be comfortable. You don't want all of, because if we do the MRI and we see that you have a bleed, do you want to go into surgery? You're telling us that no, you don't want to go into surgery. You don't want anything that will prolong your life, because at that time maybe the ailment you're dealing with is not salvageable, or there is nothing else that could be done outside of what medical practitioners have done or what providers have done. Okay, so DNRCC is comfort care. Don't do anything to prolong my life, just make me comfortable, help me with my pain, help me with my anxiety, help me with my secretions, make me sleep well. At some point I want to still be able to talk with my family in my last days of passing. Note, this is different from hospice. I'm not talking about hospice here, because that's also a different thing. But you realize that sometimes a lot of people who are DNRCC, who are being made comfortable, are on hospice. So this is different from hospice. Please, this is different from hospice, but it is DNRCC, making the patient comfortable. Like I said, EMS may recognize some things, so there are a little bit of nuances there depending on your state. But I think, don't quote me on this, but I think in Ohio, if you are DNRCCA, there is no okay to intubate and do not intubate with EMS. If you're a DNRCCA and your heart stops, they're not going to put a tube in, or they're not going to, or they're going to say, oh, you're okay to intubate, let's put a tube in. They just do it. Or, so if you're a DNRCCA, there's no, and your breathing becomes abnormal, they will probably put a tube in because your heart has not stopped or something like that. But don't quote me on that. The EMS is different. But when you come to the hospital, these are the 4 things that we kind of ask you. If you come in and you've been admitted and you say you are comfort care, we probably will send you home and be like, hey, okay, maybe, or we ask the palliative docs there, your comfort care, what can we give to you to make you comfortable, kind of set you up to be able to go home or somewhere else comfortably. But full code, we do everything that you want us to do. DNRCCA, okay to intubate, do not intubate. We do everything until your heart stops, and then we don't push on your chest. If you're okay to intubate and your breathing becomes abnormal, we will put a tube down your throat to help support your breathing. But if you're comfort care, we stop all life-sustaining measures, and then we make you comfortable as much as the patients and your family are comfortable with. I want you to know that sometimes people come in and they do not have that ability or that capacity to make these decisions for themselves, and that's where we ask family to help make that decision. That is a whole different talk, but I just want you to be aware we don't always go by what the family say if the patient has the capability to voice their understanding of what is going on, and they have the ability to say, yes, do this, yes, don't do this. But sometimes there's a lot of conflicting information with family and with the patient. The family says no, I don't want, I yes, do everything. The patient says no. If the patient has that ability, capability to understand everything that's going on, able to voice that understanding and see that, hey, this is what I want, we go by the patient. And when it comes down to family, there are some legal things that we look at as well, but that's mostly the big thing. So that is co-status if you hear about it.